March is Endometriosis Awareness Month. We're going to be talking about endometriosis.
Yeah, and I think this is a really great topic and something that comes up a lot in our day-to-day. And also something that I'm so glad that there is a month dedicated to awareness about this, because really it's something that is probably underdiagnosed, undertreated, and very misunderstood.
That's right. So on the first live, which is today, we're going to be talking about what is endometriosis, how do we diagnose it, what are the symptoms associated with it. And then on the March 19th, we're going to be talking about treatment options for both from the fertility point of view and also for women who are suffering with endometriosis, but they're not looking to conceive in the immediate future.
And then for our last live in March, on March 26th, we're going to be talking about fertility treatments and endometriosis and how that might affect protocols, medication, priming, not priming, etc., IUI, IVF, FET protocols. We're going to get into the nitty-gritty of fertility and endo.
Yeah. And then in the last, on March 26th, I'm going to tell you my own endometriosis story, because that was actually, endometriosis was part of my fertility journey. So I'll tell you all about it on the last talk. All right, so we're going to start with endometriosis. What is it? Endometriosis is a condition where the lining that normally lives inside the uterus actually escapes. And we can talk about the theories for that, but actually exists outside of the uterus. Then that endometrial tissue could be deposited in the ovaries, in the fallopian tubes, in the bowel, in the rectum. More rare cases could be the diaphragm as well. Because this endometrial tissue is all over the place in the bowel, in the abdomen, it is hormonally receptive. So when your estrogen level goes up, when your progesterone level goes up, that tissue actually responds to that. So that's why it causes inflammation in organ systems that it's not supposed to be inflamed in response to different hormonal changes.
Yeah, and really with endometrial tissue and endometriosis, those are for sure the most common. It could be absolutely anywhere. I mean, in residency, I saw a patient who had endometriosis in the lung, endometriosis in the brain. I mean, these are super, super rare cases.
Extremely rare, but has been.
But yeah, it absolutely can happen. And it's wild.
Yeah.
It's absolutely wild.
Yeah. One of the theories, it's not really understood why endometriosis happens. One of the theories is what is called retrograde menstruation, which means that menstruation, it's like the endometrial lining is supposed to go through the cervix into the vagina and out of the body during your period. And for some reason, one of the theories is that endometrial tissue goes actually up through the fallopian tubes, out from the fallopian tubes into the pelvic organs, and that's why it's spread. So that's one of the theories.
There's another theory that it could be spread by lymphatics. So the lymphatic system clears fluid, lymph through the whole body. It sort of runs in parallel to the veins in the circulatory system. And so that's why it's thought that maybe you can get to those really far off places because it's spread there by the lymphatic system. Because, even with retrograde menstruation, fertility doctor for you.
That's right.
It doesn't really explain how the retrograde menstruation doesn't really explain how it gets to the lungs,
the brain,
and stuff like that. Yeah. But there are many other theories, and I think the bottom line is that it's really not understood. Yeah.
It is a very common condition. So it's estimated that about 1 in 10 women struggle with endometriosis. And of course, in women who are struggling with infertility or some fertility, the prevalence in that is a little higher. I mean, it begs the question of whether the prevalence is higher because you're looking for it more, right? In that population versus somebody whose fertility is not a concern. They might have endometriosis, but they might be thinking, oh, it's just pain and it's not a big deal and it is what it is. So certainly we are looking for it more and talking about it more in the fertility population.
Oh, for sure. And I think that's what makes it so, so difficult with endometriosis, because it is really hard to even figure out who has it, right? So, in terms of thinking about endometriosis, so it is really common, but, what are the symptoms? What are people experiencing when they have endometriosis? So number one symptom, the biggest thing for sure, is painful periods. And when we're talking about painful periods, we're talking about not like, oh, I have some cramping, so I don't feel, 100% today. We're talking about patients who are requiring prescription strength pain medications, who are missing work, who are missing school consistently because of pain associated with their periods. They might be ending up in the emergency room because of pain with their periods. We're talking about that kind of level of pain generally when we're thinking about it. And that's what makes us think about endometriosis. So painful periods for sure is the big one. Along that same kind of spectrum, or along the same thinking, a chronic pelvic pain, chronic abdominal pain. So you can have really painful periods, but you can also have chronic pain in the pelvis, in the abdomen, that continues through the whole cycle. It can also potentially be a symptom of endometriosis.
Another common symptom of endometriosis is what is called dyspareunia, and that means pain with sex, in particularly penetration. And there are certain positions that tend to be more like deep penetration and thirsting. Those tends to be the ones that stimulate endometriosis pain the most. So again, there's a condition called vaginismus, which is pain at the insertion into the vagina. That's not what we're talking about. We're talking more about pain with deep penetration.
And because, again, you know, the vagina, the uterus, the bladder, the bowels, they're all right next to each other, endometriosis can also cause symptoms and pain around the bowel movements. So either diarrhea or constipation, or a combination of both, or oscillation between the two, and painful defecation. So having painful bowel movements, not like pain, you know, on the outside, like it could be associated with hemorrhoids, it could be associated with anal fissures, but sort of more deeper inside pain with bowel movements, or dyschezia is another symptom that we often associate with endometriosis.
Since we're talking about symptoms, it's important to know that symptoms do not correlate with the severity of endometriosis. So some women can have what is called a stage 4 endometriosis, which means, you know, it's in the bowel, or it can have bilateral ovarian mass and have very minimal pain. And then some women can have sort of endometriosis deposits all over the pelvic area and then have significant pain. So the pain does not correlate with the severity.
Yeah, and that's really, it makes it really, really challenging, again, to sort of try and find the endometriosis and diagnose somebody with endometriosis. But I think that that's something that is always, to be honest, it blows my mind. I can think of one particular case when I was a resident, and this lady came in through the emergency room. She had an ectopic pregnancy. So there was a pregnancy, her pregnancy was positive, it was for sure in the fallopian tube, and she required surgery. I don't remember exactly why, but we needed to do surgery to remove the tube. And as soon as we put the camera in for a laparoscopy, we were just blown away by the extent of the endometriosis. And she had no idea. You know, we had sort of talked briefly about gynecology. She's like, yeah, no, nothing. Everything's fine. My periods are fine, regular, no biggie, basically. And it became the complexity of the surgery, the difficulty of surgery just skyrocketed. So that case has really, really stuck with me. It really illustrates this mismatch between what you might, a patient's telling you sort of those symptoms and sort of what you're actually seeing on inside the pelvis.
Yeah, absolutely. I had a similar case as well in residency, which was an incidental finding of humongous bilateral endometriomas, which both ovaries completely stuck together. Yeah. And again, she was completely asymptomatic, had no issues, had 3 kids, no problems. Yeah. And had severe endometriosis. So I think it's important to understand endometriosis is an inflammatory condition. And what that means is that, like, what does it actually do in the body? So, like I mentioned, it could be everywhere, but because it responds to different hormones and it causes inflammation, then it can cause scar tissue. So, for example, the uterus normally, if this is the uterus, it can be anteverted, it could be retroverted. So sometimes in endometriosis, it can be retroverted and stuck to the rectum. So if this is the rectum, this is the uterus. Sometimes this space here can be obliterated by endometriosis. And that's one of the reasons why it could lead to painful intercourse. So sometimes if the endometriosis can exist in the bladder as well, causing painful urination or causing blood in the urine, that is more rare, but certainly we have seen cases like that. If the ovaries are inflamed and they have cysts on them, they can be stuck as well against the pelvic sidewall. They can be stuck against the cul-de-sac. They can be stuck against a piece of bowel, because remember, from the diaphragm to the pelvic organs, everything is kind of together. So that's why it's associated with pain, because of the inflammation and the scar tissue that it can create.
And I remember one person also described that with endometriosis, you just get this inflammatory soup. I love that mental image. This inflammatory soup that all the pelvic organs are just kind of bathing in with all these inflammatory markers. And that image always stuck with me. And I think it's really descriptive of why everything is maybe not working the way it should because of that inflammation.
But in terms of diagnosis, how do we go about diagnosing endometriosis? Well, the first thing would be like taking a history to go over all of the things that we talked about. You know, do you have painful intercourse? Do you have painful menstrual cycles? Do you have to miss work? Do you need to take medication when you're on your period? Do you have painful bowel movements? Any of those things. And then there is a physical exam. Physical exam is not that helpful when it comes to endometriosis. I mean, it could be. There are sometimes you can feel nodules in the cul-de-sac when you're doing a physical exam. Sometimes you can feel the uterus being retroverted and not mobile. That means, again, stuck against the rectum in the back. So there are some physical exam findings that you can note for sure.
Yeah. But the big thing is that even if you don't find them, it doesn't mean that somebody doesn't have endo.
That's right.
Right? And I think that's always the so challenging.
Yeah. And then there is ultrasound. And ultrasound has traditionally not been a great diagnostic tool for endometriosis because the only thing ultrasound can really tell you for sure is that there is a cyst in the ovary that looks like an endometrioma. So traditionally it hasn't been considered a good diagnostic tool for endometriosis, but that is changing.
Yeah, so there's a lot of really, really interesting research and a lot of healthcare providers who are really, really trying to get better at trying to find endometriosis on ultrasound. And so, for instance, somebody here, even at Markham Hospital, is doing a lot of endometriosis mapping on ultrasound. And so they're looking for very particular findings, particular signs that are associated with findings of endometriosis. So it's a way more detailed ultrasound with a super, super fancy ultrasound pro, which I cannot explain to you. And so there is a lot of really, really cool emerging research about this. And I think that it's going to be a really, really interesting area that's coming up for sure.
Yeah, here at MFC, we're advocating to have an actual endometriosis mapping ultrasound unit, but that requires support from the government and different resources.
And a lot of expertise, Another big thing in imaging is the MRI. So, I mean, you've probably gotten lots of ultrasound reports where it says, well, then maybe this is an endometriosis, suggests an MRI. It's important to think about this in our geographical context. So we're in Ontario, we're in a publicly funded healthcare system. We don't have a lot of MRI machines, and the wait list to get an MRI is like a year. Yeah, it's very, very long. I don't even know exactly what the wait list off the top of my head, but within that context, a lot of these ultrasounds may suggest getting an MRI. An MRI for sure is better at looking for endometriosis, but sometimes it's not always accessible. It's not always feasible for everybody to get an MRI to look at this.
Yeah. So the gold standard for diagnosis is a laparoscopy, which we're going to talk a lot about on our next Instagram Live when we are talking about treatment of endometriosis. But in laparoscopy, you're able to directly visualize the pelvic organs. You're able to see the scar tissue that we're talking about. You're able to take biopsies of that and then send it to pathologists, and the pathologists can look under the microscope and actually identify endometriosis.
Yeah, and so surgery is like the gold standard for sure in terms of diagnosis of endometriosis, but again, it comes with challenges. So now you, especially in the context of practicing in Ontario, you're looking at
even longer wait lists.
Even longer wait lists. And a referral to a gynecologist, potentially a gynecologist who has experience in endometriosis, depending on the severity of symptoms. Again, those endometriosis surgical experts, even longer wait lists. Then you're waiting for the surgery itself. Now, surgery's good in the sense it provides you your diagnosis and treatment potentially at the same time. So there's a lot of benefit to that for sure. And we're going to talk about the benefits of surgery in our next Instagram Live. But again, it's the time in which it takes to actually be able to get to that surgery can be long. I mean, year, 2 years, even longer in patients who maybe don't get referred to a gynecologist right away because they kind of get swept under the rug sometimes as well, as we've heard.
So in terms of diagnosis, there isn't a blood test that you can do to say you have endometriosis, but there are two things that are worth talking about. One is a test called CA-125. So CA-125 is actually a biomarker that is used to look at ovarian cancer. So when the CA-125 level is very elevated, that means possibility of ovarian cancer, and it's also used to see the response to chemotherapy in the setting of ovarian cancer. we know that CA-125s can also be elevated in the setting of endometriosis. So I wouldn't call this a diagnostic test for endometriosis, but something that it's worth mentioning. It's not part of any guidelines that you have to do a CA-125 when you are thinking of endometriosis. And it's certainly not as elevated as you see it in ovarian cancer. In ovarian cancer, it could be 800, 1,000. In endometriosis, it's usually like 40, 50, usually under 100. But it's worth mentioning because a lot of people have been talking about it. So again, it's not a diagnostic tool. If it's negative, it doesn't mean you don't have endometriosis. If it's positive, it could be other sources of inflammation. It could be Crohn's disease. It could be, any other source of inflammation can cause an elevation in CA-125. So it's not specific to endometriosis.
Yeah, it's a really challenging test to interpret. And I think for patients who have, let's say, milder disease, not necessarily milder symptoms of milder disease, then their CA-125s may not be elevated, but they could still very well have endometriosis. And so that's why, when patients ask me about the CA-125, I really, really spend a lot of time counseling them that, this may not change what we're going to do in terms of how we're going to proceed with things, surgery or not surgery, etc. Because that one's really, really tough.
Right. The other test to talk about is called Receptiva, and I know many people in the fertility community are familiar with this test. It's essentially a biopsy of the lining of the uterus that looks for a molecule protein called BCL6. And if it's positive, it's suggestive of endometriosis. And if it's negative, it's suggestive that there is not endometriosis. A lot of problems with this test.
Yes. So, it's actually kind of interesting. So when you, outside of the fertility world, so when you, talk to a gynecologist, let's say, who does a lot of work in endometriosis, they don't, Receptiva is not even on their radar. This has really become a test that's been really picked up by the fertility community and not really by endometriosis experts. And I think that that's really, really telling in terms of how people feel about this test. Because again, you're looking at a marker that is associated with inflammation that might be associated with endometriosis. And this might tell you that it's endo. And that might be associated with difficulties with, embryo transfers or failure of embryo transfers. There's a lot of maybes that in that whole kind of chain of events. And I think it's not, the studies on Receptiva have been very limited. Even when you go on the Receptiva website, they quote one study that was on a very small group of patients. And again, this was a study that was published more than 10 years ago at this point. And so there really aren't any further updated studies really showing that this can actually tell you that somebody has endo, and that this is then going to actually improve fertility treatments. So, I've definitely done it.
Yeah, guilty.
I've definitely done it. I've definitely done it for patients. Absolutely. But I think, again, it warrants a really big discussion in terms of, okay, what is the actual value of this test, and what are we going to do if it comes back positive? What are we going to do if it comes back negative? How are we going to interpret this before you even do the test? But yeah, it's not something that is a surefire way of diagnosing endo by any stretch.
Yeah, absolutely. So I think we've covered all the topics I wanted to cover for this first video. Remember, there is another video coming on March 19th and another one coming on March 26th. So I'm going to go and see if there's any questions.
Yeah, absolutely.
Look at the other questions that we had ready. There's one question. Can you differentiate endometritis? Oh, great, from endometriosis. Great question.
So I think that because those two words sound so similar, it can really lead to a lot of confusion. So endometriosis, and I'm going to over-enunciate here, is this overgrowth of that endometrial lining outside of the uterus, which we talked about. Endometritis is an inflammation of the lining that is in the uterus. So the lining is in the normal spot, if you will, but it's inflamed for whatever reason, whether it's a chronic infection or some overgrowth of bad bacteria or whatever. It can also be an infection of the lining of the uterus. So you can have an acute endometritis or a chronic endometritis, which is the lining is where it's supposed to be, but it's not happy. Endometriosis, the lining is not where it's supposed to be. And so I think that's basically to kind of think about between the two.
And to diagnose endometritis, which is an inflammation or an infection of the lining of the uterus inside the uterus, you would need to do a biopsy of that and then look for certain either bacteria, which they're difficult to culture sometimes, or also certain proteins as well have been associated with inflammation of the lining inside the cavity of the uterus.
Yeah.
Endometritis.
Yeah. But these are for sure things that we often talk about together. The endometritis and the endometriosis, you know, if somebody has, let's say, failed an embryo transfer of a euploid, then we do get into those things. I can definitely see why that can be a lot of confusion. Yeah.
Yeah. And while we're on the topic, I also want to talk about the difference between endometriosis and adenomyosis. Because adenomyosis is a condition that also gets thrown around sometimes on an ultrasound, and especially when it comes to fertility and where people are wondering, why things aren't working. So as we mentioned before, there is a lining inside the uterus, exists outside of the uterus, the bowel, the bladder, the ovaries. That would be endometriosis. Adenomyosis is those same glands, that same endometrial lining that actually penetrates the wall of the uterus, which is the muscular wall. So the uterus has a muscular wall and a glandular wall that has glands. The glandular wall, it's the endometrial lining. And those glands in the endometrial lining not only escape but sit in the ovary, but they actually penetrate the wall of the uterus, the muscle of the uterus, and that is what adenomyosis is.
And actually, that would be a great topic for another Instagram Live.
Yes.
Yeah.
Yes.
Actually, we should get Dr. Chan on.
Oh, yes.
Because she did a recent paper on adeno. Yeah.
That's right.
I'm going to put that one in the bank for later. Okay, so these are some questions that we had previously sent in to us. So here we go. Why does PIO stop at 10 weeks of pregnancy, and when does the placenta actually take over?
The placenta usually takes over around 7 to 10 weeks. That's when initially in the first 7 to 10 weeks, we have the corpus luteum, which is the cyst that happens after ovulation. It's making progesterone. This is in a naturally conceived pregnancy or in a natural frozen embryo cycle transfer. And usually around 7 to 10 weeks, the corpus luteum stops working, and then the placenta takes over with the progesterone formation. In a medicated frozen embryo transfer, there's no corpus luteum, so that's why we have to give you the progesterone. But again, if the embryo implants, there is a placenta growing. The placenta also around 10 weeks starts taking over the progesterone production.
Yep. And so that's why we continue progesterone supplementation, whether medicated or naturally, at 10 weeks. Because 10 weeks is actually overkill.
It's overkill, yeah.
10 weeks for sure is overkill for extra progesterone. But again, we want to give a little bit of extra rather than kind of erring on the side of not enough, right? Especially progesterone. So 10 weeks, we're super confident that the placenta has taken over in terms of producing progesterone.
And I know it is stressful for patients to just stop taking progesterone all of a sudden. So a lot of time it's like, oh, can I take it every other day? Do I need to wean off? Like, are you sure I could just not do this tomorrow? Yeah. But yes, we're sure you do not need to do it after 10 weeks. Sometimes if patients are really anxious, if they had a history of recurrent pregnancy loss, mostly to treat the anxiety, which I get, I said, okay, let's just finish your vial or, go to 10 weeks and 5 days, go to 11 weeks. But really there is no reason to go on it longer than that, unless there's specific situation with preterm birth and things like that, which we can get into.
Totally different,
Completely different.
So this is another question that we got from a little while ago. Do you still recommend NIPT testing if someone did PGTA testing? Okay, so first of all, let's go through the acronyms here.
I was going to say, let's start with
that. Okay, so PGTA refers to pre-implantation genetic testing, specifically testing for aneuploidy. So this is, somebody does IVF, we've got embryos, and now we've done a biopsy of the embryos, 4 to 6 cells, we send that off for genetic testing. And they've come back and they're genetically normal, meaning that the number of chromosomes are normal and the general size and shape of the chromosomes is normal. So that's kind of PGTA in a very brief nutshell. And so when you talk about euploid embryos, we're talking about embryos that have gone through PGTA and have been found to be, contain those 46 chromosomes and that they're normal. The other thing here is the NIPT. So that stands for non-invasive prenatal testing. So this is testing that's done when someone's pregnant. Some of the common brands, there's Harmony, Panorama, Invitae testing. In these situations, the woman is going to be, let's say, 9 to 10 weeks of pregnancy. Again, different companies have different timing of when they recommend doing the testing. But someone is 9 to 10 weeks pregnant. You do a blood test on the person carrying the pregnancy. Very important. We're not testing the embryo or the baby or that. It's a blood test on the person carrying the pregnancy. And again, you're looking at the chromosomes in the pregnancy for the fetus now to see the number of chromosomes, again, to see how they're arranged. They can tell you what the sex chromosomes are, so they can say whether the fetus is female or male. There are other levels of NIPT as well. They can test for certain microdeletions and certain other levels of testing that PGTA cannot do. Okay, so back to the question. So do you still recommend NIPT if someone has done PGTA? This is a really interesting question, and there is a difference of opinion on this. If we look at the American College of OB-GYN, or ACOG, they are still recommending that patients who've done PGTA should do NIPT. That is the American recommendation. Again, you could argue that you're testing, there's construction going on as you're now too. So the Americans do recommend to proceed with NIPT even after PGTA. The Canadians, they are a bit more kind of like, well, it's patient choice, patient decision. You should offer it to patients. You can counsel patients about it, but they don't have that same level, that same strength of recommendation that you should do it. Now, again, there are some differences between the two. So for instance, I would say number one reason that people do, two big reasons why people do NIPT after PGTA. First one is they want to know the sex of baby.
Yes, I was going to say, that's usually the number one reason.
That's a big one, which I totally get.
Yeah.
I want to know too. I'm totally with that group. Number two is that they want that extra level of reassurance. So yes, you've already done testing for the chromosomes, but some people want to retest to sort of double check in a way, or sort of to have another way of looking at it to be extra sure that the pregnancy is genetically normal, which again, I can completely understand, especially in patients coming with infertility, patients who have a history of miscarriages, recurrent miscarriages, for sure. NIPT does offer some extra levels of testing, which I kind of alluded to. So looking for certain microdeletions and looking for other conditions. Now, in those cases, the sensitivity specificity, meaning the likelihood of this test being correct when it makes a call, the risk of false positive, false negative is a lot. The tests just aren't as good. So NIPT is not as good looking for those other things as it is at looking at the chromosomes. And I think that really warrants a bigger discussion, more specific to the patient and kind of these specific conditions as well.
Another thing with the NIPT is that if you're over 40 at time of delivery, it's covered by OHIP in Ontario. This is specific to Ontario information. So, I mean, if it's going to be covered, I think it's a good test to do as well. So the way I would answer this question is, it's not so much like when somebody says to me, hey, I did PGTA, I transfer you per embryo. Does that mean I don't have to do an IPT? I basically don't say yes or no, but I go over the test, right?
Yeah,
I say,
exactly.
PGT is doing a little biopsy of the embryo. NIPT is doing a blood test that looks at the actual baby that's inside of you, and it's looking for this particular thing. So the tests are a little bit different. We do expect that they will be congruent, and they always are. I don't think I've really seen, it's not very common to see something different. It would be extremely rare. So most of the, like 99.9% of the time, patients that have done PGTA with euploid embryo, they do an IPT, and it comes back completely normal as well. So they are really two different tests. They're not exactly the same test. So I think that's important. We're not just doing the same test twice. We're doing two different tests at two different stages of development, two different technologies, looking for slightly different things. So I think it's important to be aware of that.
And we're also very, very, very fortunate that here at Markham Fertility, we do have a fabulous genetics department with phenomenal genetic counselors who are super, super helpful with going through all of these things because they understand the intricacies of these tests like inside and out.
Yeah, we have a webinar that we give to our patients who are pregnant at Markham Fertility Center to go over all of this.
Okay, so another question that we received previously. So what best prenatal recommendations?
Best prenatal recommendation. So best prenatal vitamins recommendation, I think. So certainly the most important thing in a prenatal vitamin is the folic acid. I cannot stress this enough. And yes, it has to be folic acid, not any of the other derivatives of folic acid, like the methylated folic acids. So folic acid, specifically folic acid, is the only one that has been proven to decrease the risk of neural tube defects. So when you're looking at a prenatal vitamin, you look in the back, you want to make sure that it says folic acid, not folate or folinic acid or 5-methyl tetrahydrofolate, not those things. You want folic acid. Some prenatal vitamins may have a combination of them, which is fine, as long as you have at least 400 micrograms of folic acid in there. It's okay if it has other derivatives of folic acid on top of it, but you want to have at least 400 micrograms of folic acid in a prenatal vitamin. So the SOGC, which is the Society of Obstetricians of Gynecologists of Canada, actually had a stamp of approval on 2 prenatal vitamins. One is Materna, and the other one is Centrum Prenatal with DHA. These are actually one of the least expensive prenatal vitamins out there. Yeah. So certainly worth checking it out. When people ask me what type of prenatal vitamins I should take, I usually suggest Materna.
Yeah, I think Materna is probably my go-to for sure in terms of recommendation, because again, it has been thoroughly reviewed and it does have the stamp of approval. And again, cost. That's a big deal. Yes, right.
Another thing where we're talking about prenatal vitamins is to make sure that we add vitamin D on top of that as well, at least 2,000 international units a day. Most prenatal vitamins do have vitamin D in them, but I would recommend adding on top of that, especially in the winter months, and omega-3s as well. So some of them, like the Centrum, has DHA, some of them do not. So if there's no DHA in them, I would recommend adding them in the form of omega-3.
Yeah. Because again, and this is something that I always get said, DHA is part of the omega-3 family. And that's different from DHEA, which is a totally different thing.
Which you definitely do not want to take.
You definitely don't want to take when pregnant. So there's, again, too many acronyms.
Yeah, DHEA is an androgen that you do not want to take when you're pregnant. And DHA is part of the omega-3 family.
I'm going to take a look to see if there's any questions on here, if you want to start reading that one.
So the next question is, what is a good number of genetically tested embryos to have 2 children? I love this question. And it really depends. I mean, the short answer, I would say about 4. So I always think of about 2 to 1 or 3 to 1. It really depends on many things. So, not every euploid embryo is created equal. So a day 7 euploid embryo has a lower pregnancy rate than a day 5 euploid embryo. Euploid embryos that have really good morphology, like 5AA, are different from euploid embryos that have a lower morphology, like 3BC. The age at which the embryos were created is also important. So a euploid embryo from a 30-year-old egg might be different from a euploid embryo from a 40-year-old egg. So it's important to know that every euploid embryo has approximately a 65 to 70%. We say every euploid embryo, but in general, euploid embryos have about 65 to 70% pregnancy rate. Like I said, day 7, slower morphology embryos are probably less than that. And there is also a miscarriage rate with that. And the miscarriage rate with euploid embryos is about 10 to 15%. So you have to keep that in mind. There is also the question of, if you're banking embryos and you have 3 embryos or 4 euploid embryos. Let's say you have 3 euploid embryos and you're thinking, okay, I'm great to have 1 child, maybe 2, but you're 39 and you do transfer one of them and you do become pregnant and you do have a live birth. So now you're transferring your next euploid embryo that you banked when you're 41 or 42. And if those don't work, then making more euploid embryos at that point would be really difficult. So in terms of counseling patients about the number of embryos to be stored to transfer and have 2 or 3 children, you also have to think about what is the possibility that they don't work and can they make more euploid embryos in the future.
Okay, so let's just ask some questions here. So is it okay to take DHA before pregnancy? Yes.
Yes, absolutely.
Definitely. Highly recommended.
Yes.
So again, DHA, part of the omega-3 family, may improve egg quality. So people who are trying to conceive, we will recommend omega-3s, either supplement or getting more in your diet, fish, flaxseed. So it's more than okay. It's definitely recommended pre-pregnancy. There was another question here. It was about uterine. Oh, can endometriosis cause a uterine septum, or are they not related?
Endometriosis does not cause a uterine septum, and they're not related. So a uterine septum is basically what is called a Mullerian anomaly, which means that the uterus, when it was formed in utero, it's basically 2 horns that fuse together, and then they had to, the inside kind of cavitates to form what it looks like this, a uterus. So when that cavitation or that formation happens, sometimes it's incomplete, and then you can have, looks like that, like a septum or some other Mullerian anomalies, like a unicornial uterus or a bicornial uterus or uterine didelphys. So they're not related.
Okay, so I knew this was going to come up I knew this was going to happen. So what about 5-MTHF? I was told it's the best form of folic acid.
So
You opened Pandora's box.
Smoke coming out of my ears now.
Yeah. She's going against some social media influencers. She's brave, this one, Dr. Garcia.
Well, when it comes to my patients, I feel like it's really my responsibility to,
100%,
inform. I mean, okay, so let's start. So 5-MTH, it's a derivative of folic acid. So folic acid gets absorbed in the gut. There is an enzyme that breaks it down into 5-MTH, and that is what goes into the blood and does all the things. So it is possible that in a few years, we see new research that says, hey, 5-MTH is the same as folic acid. Everybody should be on it. And I mean, I could see that happening. I don't know. The bottom line is that today, when we talk about prevention of neural tube defects, 5-MTH has not been studied in the same way that folic acid has been studied.
Yes. And
So,
I think that's worth repeating.
yes.
So we have been, the scientific community has been looking at folic acid and risk of birth defects for
10 years or more.
Yeah, even more. In the 60s, they started supplementing with folic acid. So there's lots and lots and lots and lots of research out there that shows if people take folic acid, they have a lower risk of these neural tube defects. That literature just does not exist for 5-MTHF and all these other derivatives. It's totally possible, as you said, in a few years.
I'm not saying it's bad for you. It might not be bad for you. It's just that there's just no evidence that it does the same thing that folic acid is known to do. And when we're talking about evidence, I mean, the research is overwhelming to the point that in the States, in Europe, in Canada, food is fortified with folic acid.
Yeah.
And we're talking a 72% reduction in neural tube defects.
Yeah.
When women do have children with neural tube defects, because they cannot prevent every single case, and there's also some genetic issues there leading to neural tube defects. So what we do to reduce the risk of neural tube defects in the second pregnancy is higher dose of folic acid.
And so, it's I think that's really the bottom line. As of right now, the research is really around folic acid, and that's why we're standing by it, and that's why we recommend it.
And neural tube defects are a big deal. We're talking anencephaly, which is being born without a brain. We're talking spina bifida, which sometimes is mild, sometimes is really severe.
Yeah.
We're talking like cleft lip and cleft palate. So it's not an insignificant thing that you're trying to prevent. So I feel strongly that you do need to take the folic acid. So when I have patients that tell me, I'm taking this prenatal vitamin that have the 5-MTH, I said, okay, if you already bought it, continue to use it, but I want you to go ahead and buy folic acid and then take it on top of that, because I just want to make sure that you're having that folic acid
that
as
you're
well
truly covered
in there.
Yeah.
And I understand this need of wanting to take things that are natural. I understand this need of folic acid sounds, it's a synthetic because it's made in the lab. That's absolutely correct. So it's a product made in the lab. It's a synthetic product, and people don't like the sound of these things. And I understand when you're carrying a baby, you want the absolute best for the baby. The organic mattress and the humidifier and, all the things, completely normal. And I've been there, done that. So I totally get it. So I understand this desire for people to stay away from something synthetic and take something that seems more natural, that seems to be the end product. The research just isn't there to say this is good for you. Or as good as folic acid is.
So another question here. When would you need to supplement Pregvit? Okay, so Pregvit is another brand of prenatal vitamin. Pregvit is unique in that you get it by prescription. Pregvit, again, if somebody has insurance plan insurance coverage, then the insurance would cover the cost of prenatal, so when would you need to supplement Pregvit? So again, it's really in those other things we've talked about. So looking at the vitamin D that is in Pregvit, and then working your way to sort of getting to a total supplementation of vitamin D of 2,000 units per day. And again, it does not contain those omega-3s. So again, looking at an omega-3 supplement, fish oil supplement, flaxseed supplement, whatever, that is going to get you around 1,500 milligrams of omega-3s per day. Those are the two big supplements that we would add on to, whether it's Pregvit or Materna, or not so much in Center because it has the omega-3s.
Well, thank you, everyone. If you are on YouTube, don't forget to subscribe. These Instagram lives are going to be recorded on the MFC Instagram account. And
I hope everyone has a lovely week.